Welcome to Focus on Health, a series of educational programs highlighting current health issues sponsored by the Department of Nursing at Salisbury University. I'm Dr. Mary DiBartolo, Professor of Nursing at Salisbury University and host of the program. Today's program is on the topic of movement disorders, and my guest, returning again, is Dr. Richard Bird, uroneurologist with Riverside Neurology Associates located here in Salisbury. Thanks for coming back on.
Oh, my pleasure.
Now, you've been on the program before. You've talked about epilepsy and Parkinson's in great detail, but today we're going to take a little bit broader approach and talk more about movement disorders, and then you have some exciting technology to talk to us about a little later on as far as a treatment modality. So let's start out with what exactly movement disorders are, and that we're going to focus on 3 of them today.
Yes. Well, movement disorders, somewhat by definition, are problems with people have in various kinds of movements. Either they can't move well enough or they move too much. For example, if you had cerebral palsy or a stroke, you may be paralyzed, stiff, or spastic. You don't move very well. That's not really classified under the movement disorder, but that kind of idea. People with Parkinson's disease, for example, or various forms of Parkinsonism, as there's more than one kind, often have a decreased ability to move. They become stiffer and slower, and they can't walk as well. Their posture changes, their gait, their balance changes. And so that's the negative side, but they also have the positive side often where they have uncontrolled tremors. So now they move too much in some aspects and not well enough on others. People with essential tremor, which is another one of the most common movement disorders, where people just develop a tremor of the hands and often the head or the jaw. They shake too much. They move too much, so this is excessive movement. And people with a condition called dystonia, which is an unusual movement disorder, where you not only move too much, but you move in unusual twisting, writhing kind of ways, which are very abnormal, and frequently, if it becomes bad enough, interferes with your ability to function. And sometimes, if it's severe, total inability to function.
Now, is Huntington's chorea a form of a movement disorder, but you say that's very rare?
Yeah, that's a genetic disease. It's quite rare. There are other forms of chorea which come from medications or certain strokes or certain problems with diabetes, for example, but they're quite infrequent. We rarely see those. The most common movement disorders are Parkinsonism, essential tremor, and to some degree dystonias.
Well, let's start with either essential tremor or dystonia. You pick.
Okay. Well, dystonia is a condition where people will have unusual movements, frequently the twisting variety. For example, they may hold their hand out and it'll twist like this, or they may have a kind of this kind of thing, or their legs will twist, and some people become very deformed. Some people literally almost bend over backwards or forwards or twist into a knot to the point that it's so obscene that they can barely move. I personally have not seen one that bad, but I've seen the films and the programs of people who have had this disorder, and it can be incredibly disabling. Sometimes it's of one area of the body. The head, for example. You may get a torticollis, which is a form of dystonia, where the head turns to one side and comes twisting. You may have seen the late Dixie Carter doing ads on TV for that, for the torticollis. That's one form. You can get writer's cramp, which people who start writing. It only occurs when people who are writing or holding certain objects in their hands. All of a sudden their hands will start cramping in while they're writing, and they can't stop it. They can do everything else, but they can't write because their hands will twist and deform inward like that. It can be of the leg or one side. You can have a hemidystonia. It's one side only. The other side works perfectly fine. Nobody really knows for certain why that happens, but I have several patients who have done that, who mainly of the leg or even just the arm, but often it's the leg. But I have a couple people where it's been just the arm.
Now, is it spontaneous or ongoing?
It comes on gradually,
okay.
And it can come on mainly young, teens, 20s, 30s. Can come on occasionally late in life, but most people are relatively young, and many of them tend to be genetic or have certain abnormal genes that they can identify, which sometimes helps, direct treatment of what kind of treatment people are going to do better than others with certain medications or the stimulators we were talking about.
Right. Well, hold off on the stimulator, but what kind of medications are typically prescribed? The same ones for Parkinson's, or ones
There are
some
similar ones, yes. One of the ones often we use is an old Parkinson drug, Artane, which has been an oldie goldie, been around since the 50s, which has been used for Parkinson tremors, one of the early drugs that came out. For some people with dystonias and various kinds of movement disorders like that, it can be very effective. And medications like that. Sinemet, which is a Parkinson drug, carbidopa, levodopa, can be effective in some people. Certain other medications just to try to sedate and stop from cramps, muscle relaxants, can sometimes help, usually not very effective. but muscle relaxers don't work that great most of the time anyway. On most problems, for some people they're wonderful. For many people they just make you sleepy or tired.
Is it a lifelong problem
Yes.
then, someone with dystonia?
Yes. Yeah, it's an incurable problem unless you find there's a medication or something that's happened in the brain that you can remove, which would be extremely rare. But it's a condition like Parkinson's and Alzheimer's that once you get it, you've got it. And now we have to find the best way to control it.
And you're saying it affects younger people?
Yes.
20s, 30s?
Yeah, there's some people who are teenagers, small and mid children, 9, 8, 9, 10. Dystonia deformans. By the name of that sounds, it's very deforming. And these are people that can twist up so bad they can't walk, they can barely talk, they have trouble eating. And they have perfectly normal intelligence often, but they are so distressed that they can't really move or function. That's the extreme end of that. We don't see too many of those.
So oftentimes it's a milder case,
yes,
which is good.
All sorts of different degrees of severity. Okay. Like say everything from the twisted head, the torticollis, to just a mild cramp in the hand or twisting of the face occasionally. You know, but some people have it severely, but most people, fortunately, it's relatively mild or localized.
Well, let's move on to essential tremor. Is that the one that people think about with Katharine Hepburn?
Yes.
That was her problem?
Yes. Often misdiagnosed as Parkinson's. You hear this in their office all the time. Oh, I can't have, everybody in my family has Parkinson's disease, which usually means everybody in the family has tremor and not Parkinson's disease, because Parkinson's in the family would be rare. It's usually a genetic condition. The most common reason you got it is because your ancestors had it and they gave it to you. It tends to come on late in life. Initially it was called senile tremor, but so many people got offended by that that they changed the name to benign essential tremor. Now essential is another old medical term, which usually meant we don't know why either. You know, we used to call it essential hypertension. Well, now we know why most people have it. It's genetic for the most part. But so they've dropped that term. But essential tremor still remains, or benign essential tremor, because most of the time it's not serious.
And what age you say? 60?
Any age.
Any age.
Any age, but mostly old. Mostly old.
Well, that's a relative term.
You know,
so what age are you speaking
of? And I've seen people who are teenagers that have it, but most people it's 50s, 60s on up. 70s, 80s type of thing. We're talking mainly, the vast majority are old, you know, in the Medicare up range, Social Security residents. But some people get it in midlife, and some people, if it's genetic enough and severe enough, can actually see it in teenagers. And I've got a few that have actually done that, college students and things like that have a little mild tremor, but it runs all through their family like that.
Does it typically just occur in the head or the
Can be either.
Extremities?
The most common is the hands. And it's a postural tremor, meaning if they hold a posture with their hands out like that, they tend to do this. So if they try to hold a paper or a cup and they try to feed themselves, it gets worse. And people are notoriously spilling their food on their shirts. They have trouble writing. It really gets to be a mess. They're paper rustlers. They can't hold a paper. They put their hands down, it stops. But as soon as they try to hold a posture, we have people in the office hold their hands out, and they may have a little bit of a tremor, but then when you ask them to start to do something, you'll really see it start coming out sometimes. And it can be very disabling. They have trouble feeding. If they use razors, they can't shave themselves without cutting themselves, so they have to switch to electric razors often for men. Trying to put on your lipstick as a woman is a real challenge. Many of them go without makeup because they're going to poke their eyes out or things like that. Eating, buttoning buttons, getting dressed.
And then some people can just have it in the head.
And some people have it just of the jaw.
Okay.
Most people have seen, if they've been in nursing homes, see elderly people with jaw tremor. And many people have head tremor, and usually it's what we call a titubation. We have to come up with a new name in medicine for everything.
Sure.
So titubation, instead of just saying a head tremor, it's titubation. And it's tend to be a side-to-side movement. I'm exaggerating, but some people really get bad with this. The most famous person I can think of is Katharine Hepburn, late in life. You know, had this, and it was fairly severe, and you used to read all the time about her Parkinson's disease, but she didn't have it. Her brother had it, her father had it, you know, type of thing. It runs in families.
So that definitely runs in families.
Oh yes, yes. And you can get all variations of it. Rarely you see it in the feet, but you can. And you can see some people who have it everywhere, both the hands, the head, and the jaw. I mean, you see sometimes it fairly bad in all areas. And there are some people, I call it not benign familial tremor or essential tremor, but I call it malignant essential tremor. They are so bad they have to be fed. They can't dress themselves. They can't button a button. You know, they can't drive. You know, they can't get their keys into anything because they shake so badly they literally can't.
So are the same medications used for that, or?
No, Parkinson's medications rarely help this. The original treatments were sedatives, Valium, Librium, meprobamate, for those of us old enough to remember how popular those drugs were.
That's an old one.
Anything that damps down the nervous system will damp this down. Then they found that beta blockers are very effective with this. The most common one used is propranolol or Inderal, but any of the beta blockers, atenolol, toprol, will help it. We find that with essential tremor, a common thing that really stops it often is alcohol. Most people have heard the term, I have to have a drink to steady my nerves. This is what they're talking about. Many people don't know who in their family has the tremor, but I find out that several members of their family are alcoholics. Because if they have a drink, it stops often. So they keep drinking. It leads to alcoholism because they got to keep drinking to stop the shakes because they're embarrassed by the shakes, so they keep having a little drink, have a little nip, have a little brandy, cover this up, type of thing, because it'll often stop for a while, but as they get older, it doesn't work as well.
Sure.
But that's a key to the diagnosis. Often if they've had any kind of drinks and they say, every time I have a drink, it stops, that's essential tremor. But we have to be careful because people discover this on their own and they get into sedatives, Librium and Valium, they get into alcohol, they get into other drugs to try to stop this. So any central nervous system depressant. The one we use the most is a drug called Primidone, or Myceline is the brand name. It's an old seizure drug. It's been around for about 50, 60 years. It's a prodrug for phenobarbital, so in the body it metabolizes to a barbiturate. Barbiturates are downers, and we use it for epilepsy because it helps sedate the nervous system and to stop having seizures. But we don't use the same doses. In epilepsy, we use the 250 milligram tablet. In tremor, we use the 50 milligram tablet. Once, twice, 3 times a day, sometimes more if they need it. Most people tolerate it beautifully. Some people get sedated because it's a barbiturate, and some people are very sensitive. And often it works. Nothing stops it. We're not that good. Okay, not with medications. Now, we can often suppress it or reduce it, and in some people, medications don't work at all. And I usually recommend to people, don't take any of these medications until it's bad enough that it's really starting to mess with your life. Because, a lot of people don't like taking pills, particularly if they're downers or sedatives.
Medications have side effects too. So yeah.
And many people, if I mention the medications, will say, that's all right, I'm okay now. I'll come back when it's worse. And they do, type of thing. But the good news is they don't get the other things that people with Parkinson get. All you get is a tremor. That's it. And with Parkinson's, there's much more. But with essential tremor, that's all you get. Now, with Parkinsonism, you get a lot more, unfortunately. And there are various, I use the term Parkinsonism because there's more than one kind. Just like Chevrolet is one of the most common automobiles, it's not the only car out there. And although Parkinson's disease is by far the most common form of Parkinsonism, there are other kinds. Conditions called progressive supranuclear palsy, multiple systems atrophy, striatonigral degeneration, all different forms which have Parkinsonism as their main feature, but they have other things too. For example, with progressive supranuclear palsy, people start falling very early. They eventually develop progressive paralysis of their eyes, that they can't move their eyes, they have to move their heads. They have great trouble speaking. They lose their voice to the point that they can barely be heard sometimes. They have great trouble swallowing. They can become very rigid and spastic. And they fall early. But they don't have much of any tremor. And their hands and legs move reasonably well. They can become demented. It's a much more difficult condition in the long run to treat. And it's probably the second most common form of Parkinsonism, but we don't always see all the symptoms right away. It may take years for all to show up. So sometimes we just call it Parkinsonism, treat them the same, and wait to see which one we're going to get if we're not sure right off the get-go. Parkinson's disease commonly is asymmetrical. It often starts with a tremor of one hand. And unlike essential tremor, it's a different tremor. It's primarily a resting tremor. You'll see people sitting in the chair with their hand in their lap doing this, but when they hold their hand out, it largely stops.
And when
they touch the nose, it tends to stop. But when they walk, their hands will shake, or when they have it in their lap, they tend to shake. So it's primarily a resting tremor, whereas essential tremor is more of a postural, usable tremor. And it's what we call a pill rolling. people look like they're rolling a pill in their hands. So it's more of this kind of thing, like that. And it may be unilateral, and it may be unilateral for years. The other side will never catch up. It eventually becomes bilateral, but you always got one good side and one bad side most of the time. Some people it is symmetrical. Some people have very little tremor or no tremor and still have Parkinson's disease. So there may be different forms of it. But the classical person starts with a unilateral tremor in one side and eventually becomes stiffer and stiffer and slower on that side. And the most common age group of that is actually late 50s, early 60s. The average age of a Parkinson patient is 63. So Michael J. Fox types are relatively young, in their 30s. We see them. They often have more genetic predispositions, but even if it doesn't run in the family, we can often find abnormal genes in these people.
Now, what
without
about
it
the
running in the family.
supranuclear palsy?
Yes.
Does that also come about more later in life, or
Yes,
that's younger?
usually later.
Okay.
But it can occur, rarely occurs young. It almost always occurs in the older group. The youngest one I've ever personally seen was my wife's aunt, who got it in her late 40s. But that's unusual. Most people it's 60s, 70s, 80s on up. You rarely see it in young people. But Parkinson's is actually fairly young. I've had several people in their mid-50s, right in the prime of their life, suddenly start getting this. It can be very devastating to the people who get this at this age, because most people think of Parkinson's disease as a person in their 80s, or 70s, 80s, 90s.
Right, and it's much more in the tremor,
but
as you
the
say.
most common age group is early 60s, and that means they've had it for a couple of years. So it means many people are in their mid to late 50s to develop it, and I see a lot of people in this age group with that.
So what are some of the other symptoms of Parkinson's disease besides the resting tremor?
Okay. Changes in tone of the muscles. You become gradually stiffer, slower, and more rigid. People always tend to bend forward. They tend to walk with a very shuffling gait. They start losing their balance. They drool. The speech volume drops. Like I say, they become more trouble getting in and out of a chair, in and out of a car, going up and down steps. They become very slow and unsteady over time. Variable as to how fast and how slow people may do this. But over time, they really have a gait disturbance. And occasionally, if it's severe enough, some people lose the ability to walk. Some of them will become trouble with aspirating pneumonia. People will fall and break their hips. There's all sorts of complications, as the late Pope just showed very well, when he got into this kind of trouble.
I know they can have stiffness in the face, too.
Yes.
They call that mask faces.
Mask faces.
So what are some of the medications? You mentioned a few of them already, because they're used for other things, like Sinemet, the brand name.
Sinemet is the gold standard.
Right.
It came out initially in the late 60s as levodopa. And it was found to help replace the dopamine deficiency in the brain, which is related to Parkinson's disease, because the area of the brain, deep in the brain, that produces this is dying. So it doesn't produce enough of the chemical dopamine, which is an electrical chemical which talks to the other parts of the nervous system. So we can't get dopamine into the system, so we put levodopa in, so the brain will take that to help make more dopamine by itself. It's sort of a building block, because we can't get the real drug, the compound, in there. But dopa has a lot of side effects, nausea particularly. You got to get very high doses to get it in, and it makes people very sick. So in the early 70s, they combined it with a drug called carbidopa, which blocks all the peripheral side effects in the body of the nausea and the sweating and the blood pressure problems we would have and stuff like that. And then it allowed us to have very small doses of levodopa that we can go directly to the brain. And they called it Sinemet. So it's a combination of carbidopa and levodopa in smaller amounts and different doses. And it's much better tolerated. We don't have anywhere remotely the side effects we had with levodopa. Most neurologists younger than me have never used pure levodopa.
Sure,
and know what that was like. But it's been a very effective dose. But unfortunately, over time, the effects wear off, because it works on the sick brain cells, which are still slowly dying. And eventually, it becomes less and less and less effective over time, because you don't have as much to work with over time. There's things called dopamine agonists, which are similar, Requip and propranolol, and Mirapex, rather, which are similar ones that kind of bypass that step and are very similar to dopamine, but it's like insulin for a diabetic. It's not your insulin, but it's pretty darn close. And it helps sometimes bypass that step, and sometimes that could be more effective, but you get a lot of hallucinations with that drug at higher doses. And sometimes people have sleep attacks, fall asleep like if they're driving, type of things, and impulse disorders. They suddenly become, they got to go out and buy things and do things and gamble and sex and everything like that. They got to, do things, these impulse disorders. So that can be a real problem for the rest of the family. So we have to be careful with that drug.
Are most people on like a combination of things?
Some are.
Sinemet and something else?
Some are, yes.
Whatever works to control the
But these
symptoms.
are the drugs, but all of these are progressive disorders.
Right.
So the medications help back up the symptoms. It does not back up the disease. We don't really have a drug yet that stops the disease or slows it down. There's a new drug out in the last couple of years called Azilect, which may slow it a little. It's not clear-cut. There's some evidence to suggest it may be a protector, not clear-cut. But we start a lot of people early on in their disease on it in hopes that maybe we can slow it down a little. And it's well tolerated, and it sometimes has a little effect at cutting down some of the symptoms. But we're looking for that magic pill which stops the disease, and we don't have that yet.
Well, I do know you wanted to talk about deep brain stimulation, or DBS, as an exciting alternative. So,
many years ago, the treatment for Parkinson's disease was surgical. And many older patients and people will remember back in the late 50s and early 60s, they would do deep brain freezing. They would cut a hole in the head, drive an electrode down deep in the brain, and freeze the area of the thalamus. And it was very dramatic because you could see it on TV. The people would be sitting there shaking because they're awake for this procedure. And as soon as they hit it, the tremor would just stop, and they would just look at their hands, and everybody would go, "Isn't that amazing?" And there was a doctor called Dr. Irving Cooper, who was internationally known for this, who did the vast majority of these. But it too, over time, would wear off. But a problem it causes, it's a permanent deficit. Once you've done it, you've done it. You can't reverse it. And many people are shaking both sides, so they would do both sides. And the problem eventually, again, it worked great for the arms and legs, but people often develop severe trouble with their speech and swallowing. So although we helped the outside, we worsened the inside, the middle. People had much more trouble with their gait, much more trouble swallowing, speech. So it began to fall out of favor. They began to do other techniques of surgical thing, and then levodopa came. And it worked so well that for the most part, people stopped looking at surgery. So Parkinson's then became a medical treatment, not a surgical treatment. But in the 70s and 80s, research began to go back on different techniques of working with surgical implants and various other techniques as technology improves. And in the 80s and 90s, they developed thalamotomies, where they would go back in, instead of freezing it, they would hit it in very small selective areas and try to cut down the side effects of a bilateral stimulation, which are still there, but not as bad. But the trouble is, again, that's an irreversible thing. If you have a problem with it, you can't undo it. So people began trying to put electrical stimulators in. Instead of zapping an area, we try to stimulate an area. And they put a very tiny electrode down deep into the brain, into various areas, and try to see if we can stimulate it. And if it doesn't work as a problem, we take the wire out. And virtually these wires cause very little damage at all. So it's a reversible problem. So if you get in trouble, you can take it out, and you're back to where you started from, which is kind of nice because it's much safer in the long run.
Deep within the brain lies a group of structures known collectively as the basal ganglia. The basal ganglia act as the switchboard for the brain circuits that control movement. One important structure within the basal ganglia, the substantia nigra, produces a chemical known as dopamine. Dopamine is transported to other areas within the basal ganglia, and this enables the coordination of smooth and balanced muscle movement. Parkinson's disease causes the cells in the substantia nigra to die, which results in less dopamine within the basal ganglia. This results in the motor control symptoms associated with the disease. Often, Parkinson's disease is treated with medications. Most medications increase the level of dopamine in the brain or mimic the effect of dopamine. When medication increases the level of dopamine, this indirectly enables the basal ganglia to function at higher levels, thus reducing symptoms in many patients. While medications can be used to improve motor function, it is possible that they may lose their ability to do so over time. When this occurs, the symptoms of Parkinson's disease may again become more pronounced. DBS therapy uses a medical device, much like a cardiac pacemaker, and thin, soft, flexible wires, called leads, completely inside the body. While the device is implanted beneath the skin in the chest, the leads are implanted within the brain. Electrical stimulation is then sent directly to targeted areas within the brain. Stimulation of these areas enables the brain circuits that control movement to function better. This results in a reduction of some symptoms in many patients.
Is this done on most people or just people that don't do well with the medications?
Up until recently, they had very strict criteria who could get this procedure. You had to be under 60. You had to be definitely not demented, because some people with Parkinson's dement, get memory loss. You had to still respond to levodopa to some degree, but probably having a lot of swings with the medications and a lot of side effects of the medication. And you'd have to try just about everything, you know, to see how this would work. And you're having a lot of trouble and you're becoming more disabled. So this was sort of a last desperate gasp of people young that's who they started out with. And they found that some people did so much better that they started doing more research on it. And several years ago in France, they did a study where they did 12 consecutive patients early on in the disease. They all did so well that people really began to look at this and say, well, gee, maybe we ought to start doing it on more people. Now pretty much the age restriction is pretty much gone. You can use it on anybody if they're healthy enough and if they're not dementing, but they have to go through rigorous psychological and memory testing to see where they are with this, because people who are dementing don't do well with this long term. They can sometimes get worse with this. And you still have to respond to levodopa. That's still a Sinemet. You still have to have some response to that. And some people over time lose some response to it, but they still have to have some response to the drug. So we're now using it in a much bigger crowd of people. It's becoming much more common. People are doing it earlier in their disease. Same thing with essential tremor. We use it for both Parkinson's disease and other Parkinsonism, but mainly Parkinson's disease. We use it for essential tremor, and we use it for some of the people with dystonias. And the results can sometimes be outstanding, sometimes staggering how good some people can look. You know, unfortunately, it doesn't cure the disease, and the disease will still gradually get worse. But sometimes we can make a huge difference in some of the symptoms, particularly tremors, to the point that we can often reduce the amount of medication, improve the side effects, and significantly improve the quality of people's lives. This thing does often stop the people with essential tremor, who are so bad that they can't function. And I've seen several people now who've done this, and I've seen films of other people who've had it done that shook so badly that it's like putting the TV on when you turn the clicker and the people's hands are shaking so bad it just stops. And you see people sitting there doing this and this and thing, and then they turn it off and immediately they start shaking pretty much now.
Now you're saying Michael J. Fox did not do deep brain
He did the thalamotomy. He did the thalamotomies where they went in and zapped it. But down the middle, the symptoms still don't improve much. This is very good for arms and legs, but it's not good for the middle. If you've got a bad head tremor, it doesn't really help you much. If you've got trouble with your speech with Parkinsonism and swallowing, it doesn't really help you much. It may help you a little, but not much. It's much better for the limbs, but not the center. If you're falling a lot, it may not help you much. It might not. But if your main disabling part is tremor or dystonia, it can be very effective. And they're doing it more and more.
How exactly does it work? Electrodes are implanted briefly, and then it's connected to a...
Yeah, neurons come in basically two types. We have the excitatory neurons and we have the inhibitory neurons. A go and a stop. And the whole wiring diagram of the brain is a combination of start and stop drugs. So if you have people who are rigid and can't move, we want to excite them. We want to turn that back on to some degree. If we have people with tremor, we want to inhibit that and try to slow that down and try to inhibit that to hit more stop systems. So sometimes it depends on what the symptoms are as to which area of the brain you're going to hit. So what they do is they map out the brain with an MRI, see where all your blood vessels are, where it is, and do a whole mapping by computer on the MRI. Then they, unfortunately, shave your head. Some people don't like that. And then they lift the flap. They cut you from front to back and lift the top of your scalp off. And they drill holes in the top of your head, which are about the size of your thumb. Okay? And then they, by using the computer, and they hook up the wires and they drive them gradually deep into the brain. Now we're talking about probably down about that far. That's why they call it a deep brain stimulator, because it goes in about that far. And they try to get it into where their targets, so there's certain areas of the brain they try to hit. Area called the thalamus or the globus pallidus, which is part of the basal ganglia, which is usually not directly involved with Parkinson's, but that's the part everything talks to. So they try to get that one to rev back up again. And the thalamus to try to stop some of the tremor and various things. And then they put the wire in, and then they program it. And the wire comes with 4 different little electrodes. They're just little small electrodes about that far apart. And they try to program it as to which is the electrode that works the best. So the surgeon, when he's hooked it up, the patient is awake. They're not awake for the scalp cutting and the holes. They put them to sleep for that. But the brain feels no pain. So when they're putting the wire in, the patients are wide awake. They don't feel anything. As bad as that may sound, but they're perfectly awake and they don't hear anything.
That's the part
and
they
then they
can't
turn
feel.
it on and they program it right there with the wire to see which electrode is the one, to see if they got to move it slightly and to see which one they move it. And you can tell by the sound as they're listening. They have the technicians with the sounds. It's already puts in them, but they can listen to the sound. Every area in the brain has a different sound, so they can tell by the sound where they are. And then they say, all right, let's try electrode 0, let's try electrode 1, let's try electrode 2, let's try electrode 3, let's try electrode 4, type of thing, to see which one works the best, and then try to determine, you know, do they have the 2 electrodes talk to it, or they just talk to the case? Is it going to be monopolar or bipolar? Do the 2 electrodes talk to each other, or they just talk to a common ground in the case? And the surgeon, at the time when he's putting it in, will do the basic programming.
You brought the little
And then they
gadget
seal
here.
it back up, and then they bring you back a week or 2 later, and then they hook the rest of the wires together and tunnel it under the skin and put your generator in. Now the generator looks just like a pacemaker for the heart patients. It's pretty much in the same place right here in the chest. And they run the wire under the scalp and into the
So is that an
leads.
ongoing thing, the stimulation?
And yes, unlike pacemakers, which are intermittent and temporary often, or only when you need them, or defibrillators, this runs on a constant basis. And you have to program it. And many people have to have follow-up programming to see, you know, where we're going with this, to see if we have to fine-tune it, and keep an eye on it to see what the battery life is doing. This is sort of where I come in. You know, I've been to one of these and seen how it's done. The initial programmers do most of the basic work and set it up initially, and then I do the fine-tuning later and monitor it to see, make sure the leads are still working. Sometimes the wires break. People fall, trip, slip, break it, snap it, things like that. We got to make sure it still works, that the wires are still connected. And what's the battery doing? The more voltage we rev it up to, the more the battery gets used up. So people like pacemakers have to have the batteries changed. And I've seen some people with dramatic changes in their Parkinson tremors. I've seen people with the essential tremor have almost no tremor. And I've seen, although I haven't personally seen one of these, I have one of my patients has gotten it done, but I haven't seen her back to personally see it. But I've seen some of the films of some of these terribly disfigured young people with the dystonia after a year look almost perfectly normal. Now, they put them in slightly different places. Complications can be hemorrhage. Anytime you're putting a wire in an organ, you can get it bleeding. So that happens about 1 to 2% of the time at worst. Infection on rare occasions. I've seen a person get a MRSA infection of the stimulator and eventually have to take it out because they couldn't clear it up because they're afraid it'll get back into the brain.
Sure.
Eventually take it out. And broken wires. Those are the main 3 complications you get. Now, depending on where they put it, if they kind of miss the target a little bit, you can turn it on, you can get sudden numbness and movements of the arms because you're a little bit too close to those areas of the brain. Or if you get a little bit too deep, you may get emotional changes. People may suddenly become manic or very depressed or have a lot of mood disorders. They're doing a lot of work with bipolar disorder. And I don't know actually whether it's actually approved for bipolar disorder, but they're apparently finding it can be effective for bipolar disorder, which can be a godsend for a lot of people too.
Yeah.
They're actually doing research now in Alzheimer's to see if they can stimulate certain areas of the brain to make the memory better. Even though we may not cure the disease, can we help it? This is very early on yet. We don't know the results of this. They're trying it in epilepsy. They're trying it in various other different disorders. But the main ones are tremor, Parkinson's disease, and dystonia. So when they come in, this is what we use to monitor people. We take the leader on, put it around their neck, put it over their stimulator, turn it on, and I program it using a little stylus. Oops. Using a little stylus, and just poke it in there and adjust the voltage up and down, the pulse width, the
So with
frequency.
that, you can actually program
and then program it, and I can
implant.
see right where they're there. Are they better or worse? And if they get too much side effects, I've got to back off. Sometimes the side effects come a little later in the day or the following day. Sometimes we can see almost immediately sometimes how people are going to do on it. I got a gentleman yesterday who came in with his tremor, and I revved him up a little bit. It stopped.
It's pretty amazing.
And
I mean, I've heard a lot
yeah.
about this, but I've never heard a lot of convincing
This only
evidence.
takes a few minutes. Now, the initial programming takes quite a while.
Yeah.
But the follow-up programming for the battery check, this will tell me how the battery is doing, and the battery usually lasts several years. And this is usually fairly easy. Now, nobody on the shore is putting in the stimulators. That's all being done on the Western Shore in Holy Cross Hospital, University of Maryland, Johns Hopkins, Georgetown, for example.
But they can
And
get
they're
the
undoubtedly doing
monitoring.
it in Philly. So the problem is a lot of people, I got to drive 3 hours to get a 10-minute battery check and drive back. That takes all day. So what we're hoping is we can be more convenient, do it here for the people locally, so they don't have to drive to Baltimore. And then when they have to have major resetting done, or the battery changed, or there's a problem, we send them back over there and take care of it. So I can do some of the basic maintenance work, you know, type of thing to help, you know, people locally save a lot of driving, which for a older Parkinson patient sometimes is an ordeal. And they got to park way away from some of those buildings and do a lot of walking. So I'm trying to make life easier for people by doing some of the programming locally, which can help.
Sure, and just to summarize, people are generally trying the medications first,
Oh, yes.
and then this is an
Yes.
additional therapy.
But we're introducing the concept a lot earlier, that being people aware that somewhere down the road you may be a candidate if you meet the basic criteria for this down the road. Because most people, when they first hear that, I say, I'm not that bad. Nobody's
yeah.
cutting my hold of my head and putting wires in my
Right.
brain. But you know, after a while, when you get bad enough, you'll think about just about anything.
Sure.
I tease that the people who are most resistant to get it done are bald men, because you see all the scars and the wiring in the scalp.
Oh,
It's
really?
cosmetic. You know, they can't cover it up unless they're
Yeah.
wearing hats or wigs all the time. You know, because the hair obviously goes back pretty much, and it's not a problem with women. The balder men are a little resistant to getting this done because it's cosmetic. You can see it all. But some of them really don't care at this point either.
If
They'll
it's making
do
a
it.
huge difference, like it
But,
sounds like it could.
The initial response from almost everybody is, oh no, nobody's going to do that to me. I'm not that bad. But if we talk about how this goes, and then eventually they see some of the films, and they actually get to meet some local people, and it's getting to be more and more of them all the time, I'm surprised at how many people have come to my office from other areas, because the people on the Western Shore know I do this now, so I'm starting to see the people coming in. How many people have had this done and are doing well with it? We both have a medical and now a surgical, you know, treatment for many of these disorders, which often is helping give a lot of these people their lives back. I've actually got 2 people, older people now, with severe essential tremor that are in the process of going through the procedures to get this done. Because like I say, 2 of them are virtually disabled by this tremor. They can't do anything. They're disabled just from shaking so badly. They can barely, one woman can't feed herself at all. The other one has a hard time with it, won't go out of the house because she's so embarrassed. She won't go to a restaurant. She won't go out in public. She's so embarrassed with this. So, I mean, this can be huge for some people, because some people do not respond to medications.
Well, it certainly is encouraging to have this as an option, and the fact that you can help monitor this device, you know, once they have the initial procedure done. That's good news for people on the shore.
And we're obviously hoping that someday we can treat people with this disorders in the preclinical stage. They're finding more and more that with people with strongly genetic Alzheimer's, that they can now identify it by certain imaging techniques and blood tests and spinal fluid tests that they're doing on people that aren't quite out there for us yet, but will be shortly, that they can pick it up 25 years in advance. Same thing is true with Parkinson's to some degree, that we know it's there 15 to 20 years. And the Michael J. Fox Foundation is trying to develop a blood test marker, similar to a PSA for prostate cancer, that might identify who's at risk. And if we could treat it earlier, we can't yet, but that's where the research is going, that if we can stop it before it starts, people will be a lot better off. So not only are we looking at better ways to treat the disease, we're trying to find ways to prevent and stop the disease. We're a ways away from that yet, but that's where a lot of the research is going.
Well, hopefully more good news on the horizon, and of course for now, this sounds like a very reasonable alternative to help with that.
Yes.
And I appreciate you bringing it in today and, and sharing your knowledge on this, because like I say, I've heard of deep brain stim, but I didn't know it was used, you know, as frequently as it sounds like it's being used at this point in time, because it's so effective in some people that qualify.
Yes, it is.
Now, I'm going to post some websites at the end of the program where people can get more information about movement disorders and perhaps some information on the deep brain stimulation. And again, I thank you so much for coming in today to talk about this.
Oh, it's my pleasure. I enjoy this.
And thank you for joining us for this edition of Focus on Health here on PAC 14.
Focus on Health is sponsored by Peninsula Regional Medical Center, a proud supporter of PAC-14 programming.
Hi, I'm Peggy Nalepa, President and CEO of Peninsula Regional Medical Center. PRMC is privileged to partner with PAC-14 to provide educational healthcare programming for the Delmarva region. Peninsula Regional Medical Center, a proud supporter of PAC-14 and public access television.